Welcome, everyone. My name is Olivia Allan, and I have the very sincere pleasure of serving as the Executive Vice President and Head of the Events Practice at Landmark Ventures. A very warm virtual, great seeing you again to our Social Innovation Summit community. And for those of you who may not know us just yet, welcome. We are so glad that you're here. SIS is a platform designed to elevate groundbreaking ideas and innovative leaders who are changing the world for better. Now, for those of you who may not know the Social Innovation Summit, I am so thrilled to invite you to join us for our two-day flagship summit that will be held in Los Angeles, California on June 6th and 7th. It's coming up really soon, so please visit our website at www.social.innovation.com while there is still space available to register. Now, throughout the year, SIS is honored to partner with trailblazing organizations working within our society to amplify conversations and explore solutions to the biggest issues of our time. That's why we've teamed up with AARP on this special event series to elevate the national dialogue on the issues surrounding longevity. Now, in partnership with AARP, we bring you Longevity Plus, a series of conversations with renowned experts and industry leaders aimed at helping you understand how longevity is changing and what it means for the most important questions facing businesses and organizations, both now and in the future. Together with AARP, SIS will explore how to tap into the opportunity of longer life and support those who may be missing out. Now, today is extra special. The first is always special, and this is our first discussion in our series where we are going to answer questions such as, how can we celebrate the long-term advances that brought us to this moment, while also exploring the current state of affairs and acknowledging a growth in disparities? As mentioned, we are so honored with our speakers today and our friends at AARP. Dr. Stephen Woolf of Virginia Commonwealth University will be joining us. Also, Dr. Kruti Ka Amin of KFF and Dr. Jay Oshansky of the University of Chicago, along with Dr. Erwin Tan, who's the Director of Thought Leadership of AARP. I can't wait to get started. And just a few bits of housekeeping. We've sent all attendees a digital brochure with speaker bios and the agenda for today, and we're taking questions from the audience that our panelists will answer toward the end of the discussion. So please submit your questions for our panelists through the Zoom Q&A function throughout the event. Now, if you'd like to turn on closed captioning, you can simply do that by navigating to the bottom of your Zoom window and selecting Show Captions. Now, I am so pleased to welcome to the stage someone I count as a friend and one of the most incredible partners you can ask for, Ms. Staci Alexander, who's the Vice President of Thought Leadership at AARP. Staci, welcome to the stage.
Welcome, everyone. My name is Staci Alexander, Vice President of Thought Leadership at AARP. It is a pleasure to be with everyone here today. We at AARP are dedicated to empowering people to choose how they live as they age. Our thought leadership team works to elevate groundbreaking ideas, convene innovative thought leaders, and advance work to change paradigms and surface new solutions around the ways that we live and age. Today is the first event in a 4-part virtual series called Longevity Plus, in which we are so pleased to partner again with Landmark Ventures, host of the Social Innovation Summit. What brings us together on this series is a deeper look at longevity. We are in an exciting era where global investors are making big bets on the scientific exploration of how to advance human longevity. We know that what emerges will not operate in isolation, but intersect with the most pressing health and economic issues of our time. Today is our first of a series of conversations with experts and industry leaders aimed at helping us understand how longevity is changing and what it means for the most important questions facing businesses and organizations, both now and in the future. Together, we will explore how to tap into the opportunity of longer life and support those who may be missing out. With that, I am pleased to introduce my AARP colleague who will moderate our exciting conversation today. Again, thanks for being with us.
Good afternoon. Thank you, Staci, for that wonderful introduction. My name is Ian Hartman O'Connell, and I'm a Director of Policy Integration at AARP. As Staci has said, we appreciate all of you joining us today for the first of multiple sessions comprising our new Longevity Plus series. A couple of quick notes before we start. I just want to follow up on what Olivia said. We encourage everyone tuning in to enter your questions into the Q&A feature throughout our time together. And also, we are very pleased to offer closed captioning for this event. To activate, please be sure you are viewing the event from the Zoom desktop app and navigate to the bottom of your window to select Show Captions. So let's get started. I'm honored to be joined by Dr. Stephen Woolf, who's the founding director of the Center on Society and Health in Virginia Commonwealth University, and C. Kenneth and Diane Wright, Distinguished Chair in Population Health and Health Equity. Dr. Woolf has edited 3 books and published more than 200 articles in a career that is focused on raising public awareness about the social, economic, and environmental conditions that shape health and produce inequities. So Dr. Woolf, welcome.
A pleasure to be here.
So let's set the stage here. We know that life expectancy has increased at an extraordinary rate over the past 120 years, from roughly 47 years at the beginning of the 20th century in the United States to more than 78 years today. By some estimates, half of the children born today in the developed world will live for 100 years. And yet we know that recently life expectancy in the United States has fallen to levels not seen in quite some time. So what do you see as the key factors in these trends?
Well, the good news is that there has been remarkable progress. In the past century, we've seen life expectancy climb, partly because of advances in public health. So earlier in the 20th century, improved sanitation, the introduction of antibiotics and vaccines, later on, the discovery that smoking caused cancer and people decreasing their smoking rates. And we've also had some remarkable advances in medical science that have allowed us to really improve the early detection of diseases and the treatment of diseases. The United States has had an important role in leading that effort. The bad news, though, is that our progress in increasing life expectancy has fallen off the pace of other countries, and it didn't start recently. It began in the 1990s. So since then, US life expectancy has not increased at the same rate as in other high-income countries. Then after 2010, it plateaued altogether and stopped increasing. And then during the COVID-19 pandemic, we've experienced a dramatic decline in life expectancy.
So you referenced kind of that emerging national dialogue about these drastic shifts in longevity trends. And a few public health commentators, I feel like yourself included, have pointed to evidence that data from years past was kind of obscuring these negative trends that are really emerging now or over the last few years. You know, kind of what is your reaction to this, that the positive data from 20 years ago was kind of overshadowing some negative public health challenges that we were facing?
Well, I'm not sure that the data was hiding it. Those of us in the field have been aware of this for some time and trying to sound the alarm. National statistics of the sort that the federal government typically puts out from year to year usually compares our statistics from one year with the statistics from the prior year.
Mm-hmm.
And so those year-to-year changes are not real dramatic, and it doesn't allow people to see the long-term trend. It's when we step back and look at how things have been going over a longer period of time that we start getting some really disturbing patterns. And a decade ago, a major report was released by the National Research Council called Shorter Lives, Poor Health that documented the scale of this problem. But unfortunately, public attention to this issue hasn't been great.
I'd like to just kind of follow up on that one point. I mean, why do you think that is, that public attention has kind of wanes with this issue, even if it's kind of, there are some major issues affecting communities across the country?
Well, I think there are a lot of factors. As a society, Americans tend to think of themselves as number one. And it's hard to get our heads around the idea that we don't have the best healthcare system in the world and that we aren't the healthiest population in the world. So it's sort of a counter narrative to what we would typically believe. Also, we spend a lot of money on healthcare. We spend more on healthcare than any other country in the world. So the expectation is that we're getting something for our money, and the idea that it's actually the opposite, that we do worse than people who spend less on healthcare, is also difficult. Agencies that are responsible for health research, like the NIH, and get large appropriations from Congress, are not real excited about going on the Hill and testifying that Americans are doing worse than people in other countries. So there's a lot of optics that I think gets in the way of thinking objectively about what's happening.
So I want to follow up to that and say, it looks like according to the data that we're seeing at AARP, that the longevity dip over the last couple of years or last year in the United States is worse than some of their global counterparts. Are there factors unique to the United States that you, from a public health perspective or another perspective, that you'd like to highlight for our audience?
Yes. Well, so again, to put this in perspective, what happened recently during COVID-19 has a set of explanations for it, why the US did so poorly around COVID-19 compared to other countries. But as I said, there's been a systemic issue going on for some years, and those factors rolled right into the pandemic. So we can talk about what these systemic factors are that predated COVID-19, and then the additional set of issues that were layered on top of that during COVID-19.
So you go right into the next question that comes to my mind, which is you've written extensively about these systemic inequities in our healthcare system that have been driving this declining life expectancy. What are some of the 2 or 3 factors you'd like to highlight for the audience in terms of that systemic inequity that you've written about?
Well, let me try to break this up into 2 sections. So one is, what is it systemically that's making America do worse on health issues than other countries? Mm-hmm. And to try to be as quick as possible about it, our analysis over the years has identified 5 factors, 5 buckets. One is our healthcare system, which has a lot of problems with it that make U.S. healthcare different than in other countries. Another is our health behaviors, how much we eat, our physical activity levels, and so forth. The third is social and economic factors, inadequate education, high poverty rates, and income inequality. The fourth is our environment, the physical and social environment, which adversely affects our health. And the last and potentially most important of all is policy choices that affect all 4 of those. That set of 5 issues has been affecting the health of Americans for some years now. Mm-hmm. That rolled into the COVID-19 pandemic and resulted in massive losses in life expectancy, very large death rates compared to other countries. You bring up the issue of inequities, and we have deep inequities in our country where health outcomes vary starkly, especially around race and ethnicity and socioeconomic status. So poor people, people with limited education have much lower life expectancy than people in other groups. And people of color, Native Americans, African Americans, for most of our history have experienced very large disparities in health outcomes.
So it feels like a connected web in what you're talking about. So I know that it's a center on the Center on Society and Health. I combined the center into 2 words. You talk about and you work on the connected dots between the social factors, health, and these longevity trends. And it's our understanding that your team is looking at these issues across the country, but also region by region. So what are you learning through this research? And are there certain things you're learning about in comparing regions that you think could be extrapolated across the country?
Yeah, I mean, I think one of the things that is important for me to emphasize, I'm a doctor, so it sounds a little weird for me to say this, but healthcare actually is not the major factor driving these problems. Mm-hmm. Healthcare only accounts for about 10 to 20% of health outcomes. So most of our health trends are being driven by social and economic conditions. And most of the work of our center has been raising awareness about the importance of education, income, jobs, wages, housing. A number of policy areas that most people don't think of as health policies are actually the most important drivers of our health. So when we look at regional differences around the country, we see, for example, very striking differences by states. So for example, in 1990, New York and Oklahoma had the same life expectancy. And in the years that followed, New York's life expectancy climbed dramatically so that it now has the 3rd highest life expectancy in the country, whereas Oklahoma ranks 47th.
Wow.
So why did that happen? There are a number of possible explanations we can think about, but a very important one has to do with policy choices that the state of New York made that Oklahoma did not make. These are policy choices that include some policy areas that people think of as health related, like Medicaid expansion or tobacco taxes. But a lot of it has to do with policies around education, taxes, minimum wages, that really are also hugely important in explaining these health disparities.
So I hesitate usually to ask people for a crystal ball question, but we're going to go ahead and do it. If you looked ahead to 2050, how do you expect these trends? What do you expect these trends to look like? Do you see an improvement in the United States and around the world, or do you think there's going to be this disparities across the U.S.? Like, how do you see the next decade or so, or more, in thinking about life expectancy?
Well, the trajectory is really in our hands. We actually know what to do to fix this problem. We can get back on track and begin to compete again with the excellent health that other countries are achieving. The real issue is not a lack of solutions, but a lack of political will. So if we put our minds to it, our country can do better, and the trajectory that we currently have can change. There are now more than 60 countries that have higher life expectancy than the United States. 17 of them have had higher life expectancy for 50 years, 50. Wow. So they figured something out as to how to improve better health and to achieve better health. And we can apply and adapt those, Americanize those to improve our health outcomes. The problem really is the political polarization in our country that I think is going to get in the way of pursuing those kinds of changes. If we keep the status quo and continue doing what we're doing, I'm not optimistic that things are going to get better. And I think by 2050, we'll still be talking about deep inequities in health, and probably our statistics will be even worse compared to other countries.
So I want to end on a positive note, Dr. Woolf. So let's think about what's one thing for people watching today that they could take away and maybe make a contribution to not keeping the status quo and making an improvement. Is there certain things or a certain factor in particular that you would highlight for them to think about as they move forward in their work?
Well, the thing I would emphasize is to keep your eye on policies affecting social and economic conditions for reasons that I've already mentioned. So when we have debates in our country about jobs, about wages, about building the economy, those have implications for our economy and our wallets, but they also have implications for our health and longevity. We're now reaching the point, and this is a new development, where the death rates of children and adolescents have started climbing. This hadn't happened in my entire career, but it's happening now. What that means is that our children are less likely to reach age 20 than they were before, just a few years ago. So we're now at a point where these problems have gotten so bad that our next generation is destined to live a shorter life. We can do something about that, but the answer has to do with dealing with these social and economic policies. Broadening access to healthcare, dealing with the uninsured, improving the quality of our healthcare system, of course, is important. But the real sea change is going to occur when we start addressing those social and economic policies.
Dr. Stephen Woolf, we really appreciate the work you do, your time today. It's been a pleasure with you and kind of framing up our conversation about this. We call it Longevity Interrupted. We're going to move along to a panel of experts to continue the conversation and explore some additional nuances. And again, if you have questions in the audience, please submit them on the Q&A feature. Thank you very much, Dr. Woolf, for your time today.
It's been a pleasure.
Welcome back. It's great to have to be joined now by three exceptional thinkers around today's topic of longevity, who are going to bring us a bit deeper in today's conversation. I'd like to start with a question for Dr. Jay Olshansky. Dr. Olshansky is currently a professor in the School of Public Health at the University of Illinois, Chicago, research associate at the Center on Aging at the University of Chicago, and at the London School of Hygiene and Topical Medicine, and chief scientist at Lapitus Solutions Incorporated. Dr. Olshansky, it's great to visit with you again.
Thanks for having me.
Yeah, you have written quite extensively about a number of high-profile academic publications about what you describe as the most important metric of success for medicine, which is extending health span. So for those joining us today who may be unfamiliar with health span, could you explain it and how it differs a little bit from the conversations we have on extending longevity?
Sure. And thanks for having me here, by the way. And I'm delighted to be involved with anything associated with AARP, since I'm a member, of course.
I appreciate it.
Yes. So it's not really very complicated, and everybody knows what health span is intuitively. First of all, if you consider if you consider the lifespan of an individual, let's just say it's 80 or 85 years, for example, health span is the number of years or the proportion of life that is lived in good health. Almost everyone experiences some level of frailty and disability near the end of life. Some experience it in the middle, but for the most part, it's the amount of time that we spend healthy. And in my view, it's the most important metric that we should be considering today going forward, for reasons that have to do with why I think there's limits to how much life expectancy can rise, but that's a different issue at the moment. But health span, in my view, is perhaps the most critical metric that we should be using and looking at right now.
All right, so we'll come back to that, but I want to introduce our second distinguished speaker, Dr. Kritika Amin. She's an associate director for the program on the Affordable Care Act at KFF. Dr. Amin, it's my understanding that one of the many projects you oversee is KFF's Health System Tracker project. I'm sure from a data perspective, the last couple of years have been quite tumultuous in terms of data collection and analysis of health systems. You know, what have you learned from the global perspective of the tracker, and how it connects to longer term trends on life expectancy in the United States?
Right, thanks for having me. And like you said, the last couple of years have truly been valuable with so many rapid changes and successive changes to have all the data, but it's been tumultuous to say the least. So to put things into context, the US was underperforming on health outcomes compared to other large wealthy countries before COVID, and that trend got worse since the pandemic. In 2019, life expectancy in the US was 3.8 years lower than the average for other large wealthy nations. And that difference grew to 6.3 years in 2021. So Americans already lived about 4 years shorter lifespans, and that difference increased to about 6.3 years in 2021. And for the US, life expectancy fell across the board, but the US health system systematically fails people of color. We looked at premature mortality using all-cause excess deaths during the pandemic and found people of color lost more years of life on average during the pandemic.
It's quite stunning data. So we'll come back to that as well, but I want to transition to my esteemed AARP colleague, Dr. Irwin Tan, Director of Thought Leadership for Health at AARP. Irwin, I'm curious to hear your insights from your experience as a clinician. You know, when you're treating and managing patient care, how do some of the conceptual considerations we've heard about from Dr. Woolf and Dr. Olshansky and Amin, how do some of these conceptual considerations kind of be implemented as healthcare is delivered at the patient bedside?
Yeah, thank you, Ian. And I could see, thinking about the places I've practiced, how within even one city, whether, you know, in New York, working at NYU Medical Center or Bellevue Hospital. In San Francisco, it was UCSF versus the county hospital, or in Baltimore, it was Bayview Medical Center versus the Johns Hopkins Mothership. In each of those communities, the people that I saw, their health at the bedside was often determined, as Dr. Woolf said, by things outside of the healthcare system. And that's what we saw, that when people come to you, it's because of the accumulation of experiences they've had over life. So that life course, thinking about the decreased life expectancy among our youth is something that's critical, something that we at AARP are very interested in, about health across life course. In terms of health span, patients often wanted to be independent. They didn't necessarily want extra years, they wanted more life in their years. So I think everything that has been said, I definitely saw, and I'm really looking forward to this conversation.
So I'm just going to quickly reflect on the conversation I just had with Dr. Woolf, and we touched upon, the impact of inequities both in our health system, and also there's this angle that you guys are all referring to about kind of there's also a wealth and environmental impacts on declining longevity. So I want to pose this question, as we talk about the recent challenge of declining life expectancy in the US, is there an underlying cause of these disparities that you'd like to highlight for our audience? Irwin, I'll start with you.
So, the issue of how life expectancy in the US, especially in 2021, compares to other countries is even more dramatic when you consider that for American Indian, Alaska Natives or Native Americans, that life expectancy in 2021 was 71.8 years at birth. You know, sorry, at 2019, and it dropped to and for men, actually, it drops for the group in general, it drops to just over 65 years. So I think that is a consideration when you think about how different regions do. The geographic disparities between communities and the geographic disparities even within groups in a community is important. I was just at the NIH's Geroscience Summit, and we know, for example, that in terms of the biological rate of aging, how one ages throughout life. You know, aging is something that starts at birth and ends when we die. That issues like physical activity and diet are critical. Those are the critical interventions. But we can't think of those as individual choices. We have to think of that as people living in their environments, given the opportunities they have, the food that's available, the options that are presented to them. And that accumulation over time is what causes some people to experience age differently and to have shorter life expectancy. And I think, you know, we often say falsely that what does not kill you makes you stronger, but over a lifetime, all those insults, it's almost like, you know, the weathering away at a mountain, right? That's what it's called sometimes, weathering. And you know, at the summit, they talked about how the Department of Defense is interested in understanding how U.S. service members, Marines, and Army soldiers, after a lifetime of carrying 150-pound rucksacks, are experiencing accelerated aging. Well, what happens if you experience, you know, poverty, racism, you know, a lack of adequate opportunities to exercise and good food? That also wears down on you over time. And I think that's what we're seeing. You know, and we've seen it on the decreased life expectancy, and we're seeing it more acutely with an immediate you know, pandemic, like what happened with COVID.
So, Dr. Amin, Erwin went through a whole host of underlying causes of disparities. So I don't know if there's one of them that you'd like to highlight, or if there's something that kind of emerges from your research in KFF.
Right, like, so I was saying, of the 14.8 million years of life loss in the US, 59% of those were among people of color, who represent 40% of the US population. So 59% of years of life loss among 40% of the population. And these are premature mortality rates. And so that means people of younger ages are dying at a higher rate among people of color. Younger people of color may have been more likely to be exposed to the virus because of employment and living conditions. People of color also face broad disparities in access to healthcare, as well as social and economic factors that drive health. But there are also other factors brewing. So amid the pandemic, the substance use crisis has also continued to get worse in the US. Same with, in addition to the overdose deaths that have been increasing, firearm mortality, accidents, pregnancy-related mortality have also been increasing.
All right, so Dr. Olshansky, again, thinking of within the context of your work on health span, but just generally, you know, are there certain disparities we've talked about today that you think really have a significant impact on declining longevity?
Well, all right, let me, you know, we need to step back for a second. You cannot have a discussion about human life expectancy unless you begin with a basic understanding of biology. Duration of life is driven by biology. It is influenced by all of the variables that we're talking about, these social determinants of health. But my goodness, if you don't start with biology, you don't realize that there are, in fact, limits to how long we are capable of living. So even if you look at the subgroups of the population that are living the longest, that have adopted the healthiest lifestyles, that have access to medical care, they still age, they still grow old, they still die. Their life expectancy is several years higher than the rest of the population. But influencing the underlying duration of life for the species is the biology. There's a reason why mice live for 3 years and dogs live for, you know, 10 years, and humans live for, you know, about 80 years. And I actually think we can go up to about 85. So there's when we start out by suggesting that half of the babies born today will live to 100, that is a non-starter. That is not going to happen. We're lucky today if we can get 5% of the birth cohort living to 100. Doubling it to 10%, I think, would be astonishing. There is zero evidence in the medical or scientific literature to suggest that half of the population can live to 100. So everything that we're talking about here is about the things that we do to shorten life. And, here in the United States, we're really good at it. At shortening life, we become obese, we smoke cigarettes, we have all of these disparities that we're talking about. But even if you eliminate them, and I mean virtually eliminate all of the disparities, everybody adopts a healthy lifestyle, we're still going to age, we're still going to grow old, we're still going to die, death is going to occur. Life expectancy, in my view, will not be that much higher than it is today. And in part, that has to do with the insensitivity of the metric of life expectancy. And I think we need to be aware of that.
So I want to build on that, the points that you're making, and ask you kind of, there's this conversation brewing about, the science of longevity and these ideas that we can extend life even further. And it sounds to me like you are questioning kind of the underpinning of those conversations.
Absolutely. In my view, life extension should not be the goal of everything that we are doing in the world of public health and medicine. Clearly, if you've got a health issue, you go see your physician, and you try to get your physician to help you solve that problem. But life extension is a problem if it is not accompanied by health extension, by the health span that we're talking about. So the worst scenario is to make us live longer into what I refer to as this red zone, this period of life where frailty and disability rises at the end. We don't want to be in there. We don't want to experience that frailty and disability. We want to be as healthy as long as possible. And in my view, that should be the primary emphasis. And that's the point that Erwin was making before. There's a whole group of scientists that are zeroing in now on the underlying biology, suggesting that that should be the target, that we now can influence the underlying biological forces that drive not just duration of life, but quality of life. And if we don't do that, if we fail to influence the underlying biology that influences duration and quality of life, we may very well not like what happens if we make ourselves live longer. We probably will see an increase in the prevalence and severity of Alzheimer's disease and other related conditions involving components of the body that weren't designed for long-term use.
Fascinating. Dr. Amin, I want to kind of transition to this conversation and disparities, and you work so much around data collection. Are there disparities in being able to access data from different communities or different parts of the United States, and kind of understanding kind of the challenges there and how you might overcome them?
For sure. While we have more data now, the data aren't perfect. So during the COVID pandemic, we were getting data from the CDC, but CDC is limited by which regions that they get the data from. Like to the converse, adding to what Dr. Olshansky was just talking about with life expectancy and quality of life is important here. But the tragedy is that these are preventable deaths and preventable premature deaths that are also occurring here. So one example of that is most Americans could have been vaccinated by early June 2021 in the US for COVID. Through early 2022, over 234,000 COVID-19 deaths could have been averted with timely vaccinations. And the US continues to have the lowest COVID vaccination rate among peer countries. So on these data, we have more information that's timely, but again, we only get a little bit of information for factors around inequities. We have more data around race and ethnicity, but social and economic factors also play a part here. And we don't really have data around people's income levels or social economic status to be able to also look at these outcomes.
So Erwin, I'd love to turn to you and build on the insights we're getting from our fellow panelists. And is there an example of a successful initiative or intervention that you'd like to highlight that have been implemented, whether it's to increase health span, as Dr. Olshansky talks about, or to increase longevity, or however you want to kind of think about it? But is there a successful initiative that you've seen that we can kind of extrapolate lessons across the US?
Yeah, I think that I really agree with everything that has been said, and I want to say that whether it's health span or, as National Academy of Medicine has stated, global healthy longevity, these are important pieces. The idea that we are extending the period of good health and broadly define it to include social, cognitive, physical function, that people can live the way they want to as they age, as we say in AARP. That I think is critical. And to provide some hope, there, it's audacious. No more audacious than the geroscientists like Jay are. That the National Academy has proposed that by 2050 we could have a global healthy longevity society, right? Audacious because no society has had it yet. But there's certain structures that we can have that take advantage of the fact that people live longer, and as people live longer, provide the environment that allows them to age better. And I think the data is very critical. As I think everyone would agree here, aging is not a disease, but being able to measure how we age is important. For example, the idea of, I think Jay talks about that red zone. Some geriatricians might call it multimorbidity, that once you have one disease, chances of getting a second one are higher. Once you have two diseases, the chances of getting a third one are higher. It all kinds of stacks up. So how do we then prevent not a specific disease, but that sort of, like general cascade toward multimorbidity? Well, multimorbidity is not an ICD code. It's not something that we currently measure, right? But that perhaps should be something that we take a look at so that we can track by geography how people are aging. Or as some of the scientists at the Geroscience Summit were talking about, we often talk about, how old are you, both in biologically or chronologically? Well, instead of looking at an odometer, think about a speedometer. How are each of us aging, and how can we affect that at that moment? But I agree that the key is, I think that phrase, adding more life to years rather than years to life. That's what I've heard when I was a clinician. That's what Dr. Oshensky is saying, and that's what I heard at the National Institute of Health Geroscience Summit.
So Dr. Olshansky, I want to turn to you and just thinking about health span, are there certain things you think that steps we can take, or is there a certain approach that you'd like to highlight for our audience that you think would kind of extend that health span, those years of healthy life that Erwin just talked about?
Yeah, it's a good question. It's the right question to be asking. And of course, the answer is to control what we can control. So what we can control today is, in terms of the decisions that we make individually, not necessarily as a society, that we can control individually. It's diet and exercise. Exercise is, roughly equivalent to an oil, lube, and a filter for your car. You don't have to do it, but it makes your car run better, and exercise makes your body run better. It has a powerful influence on our quality of life, no matter how old you are. People who are over 100 and exercise benefit that day. Diet is critical. These are things that we can control today. Now, the societal forces that are influencing all this, which is what Dr. Amin is talking about. Of course, these are other areas that we can pursue systemically. But individually, of course, there's lots of things that we can control. When I give a lecture on this topic, the one thing I say, which usually gets the hair up on the neck of some of the folks in the audience, is I say, the only control we have over our duration of life is to shorten it. And we exercise that control all the time. Once you avoid the things that shorten life, then it's underlying biology that's driving everything else. And it's not like we don't know what those things are. It's diet, exercise. It's avoiding excessive exposure to sun. We know what we can do, which is why what Erwin's talking about in this geroscience initiative, it's this new public health initiative that is now launching and taking off and is extraordinarily exciting in its potential to influence how long we live and how healthy we are.
And I think, Jay, what you say is actually very critical, because when people think of geroscience, we're thinking about some miracle pill. But what you're saying is that we already have interventions. And as we potentially wait for a chemical intervention, to remember that that we have solutions like exercise and diet, but that it's not, the problem is not that individuals aren't taking the opportunity. I mean, it does take the person, the place, the policy, but that what we have to do is create a society that makes that available and and accessible for everyone. I think that's the key. And that's where the policies that KFF are talking about intersect with the biology that you, I think, Jay, are talking about as well.
It's not as complicated as some people make it out to be. Look, we learned how to make these teeth last for 100 years by taking care of them. We've turned vision problems into a nuisance with glasses, and I had this cataract removed just a couple of weeks ago. I wear hearing aids now. So we've turned a lot of these issues associated with aging into nuisances. And I think that's what we need to learn to do going forward while we're waiting for geroscience to come through with this initiative that's going to allow us to slow aging.
So Dr. Mean, I don't know if you have anything to add to this conversation, or we can turn to a new question if you'd like.
Yeah, I think that's right. Risk factors are part of the reason why we're seeing differences in life expectancy between the US and other large and wealthy countries. US has higher rate of obesity compared to other large and wealthy countries. The US also has higher poverty rates and higher inequality. In other large wealthy nations, essentially everyone has health insurance coverage. That's not true in the US. Uninsured rate has decreased during the pandemic. But 8% of the US population was uninsured as of the latest data. And in KFF polling, we found that 4 in 10 adults report that they or a family member in their household put off or didn't get care because of cost reasons. And so even for people with insurance, affordability is an issue, and there's not a one access model here in the US.
Sorry, go ahead.
And I can add, there was a question about age-friendly cities. I mean, I think those are local initiatives that can help create those changes, those opportunities to, as Jay said, the things that we know are important interventions. And I think that's where, that's where we would love to turn to the audience and in terms of the follow-up questions that we have about, I think that the solutions are out there, but it does take the political organization, the elevation to seize upon them.
Interestingly enough, in Chicago, there's a street called Midway Plaisance at the University of Chicago. On the right side is the University of Chicago. Life expectancy is way up in the 80s. On the left side, you have another subgroup of the population where life expectancy is in the 60s. They live across the street from each other. And yet you're seeing dramatic differences in life expectancy. It's like they're a half a century apart. It's quite dramatic.
It really is, and it's funny because we were talking about New York earlier, and where I grew up in Windsor Terrace, and if you drive a half mile, the life expectancy in Brooklyn can fall off by 15 years. You're exactly right. One thing I want to just turn to quickly before we turn to audience questions is all of us work across different fields, right? And so there's the private sectors, corporate executives, healthcare providers, policymakers, community leaders. It seems like some of this work happens in silos, and how do we? I'll start with you, Dr. Amin. How do we kind of break down those silos and work in a connected way across these different systems to whether, in extending health span or extending longevity? How do we kind of collaborate across these different areas?
So KFF does not take policy positions or endorse interventions. And so I'm not allowed to pick a policy or proposal here. I'll leave it to others to advocate. For life expectancy, the data are clear that the US is an outlier here. Almost all countries experienced life loss during COVID, but most other large wealthy countries did not experience it to the same extent that the US did.
Okay. So Dr. Olshansky, again, collaborating across different sectors, are there approaches or ways you kind of think that we can improve?
Oh, of course. Look, the National Institutes of Health were built on silos. You saw the breaking down of the silos just recently, relatively recently, with Dr. Felipe Sierra, who used to run the biology division at the National Institute on Aging, and his colleague Ron Kohansky, who's still there. They did groundbreaking work to break down the silos that exist at the NIH. There's a lot of money that goes towards cancer, towards heart disease, towards Alzheimer's, and they're all related to each other. And so I think as they've broken down those silos, research scientists have begun to work together. They've begun to understand that there are multiple forces working simultaneously to influence our health, quality, and duration of life. And certainly they've begun at the top, and it's begun to influence the actual science that's going on by the scientists that are in the trenches, now recognizing that there are multiple forces that are influencing all of these factors.
All right, before we get to a question, Erwin, just anything to add? I know we speak about collaboration across the public, private, and nonprofit sector quite substantially at AARP.
Dr. Amin talked about measurement, and I think just even measuring the economic benefit of having longer lives that are healthy in terms of health span I think is important. And that's something that we try to do. One of my colleagues at AARP, as you know, has been working on the longevity economy outlook. Like, what is the economic activity that's generated by people living longer? And it's considerable. And I think there's that potential as well. So I think that's one place that one way that we can start that conversation. But the other question is, when we have these interventions, who would benefit the most? If we had a magic pill that could increase health span and we gave it to the U.S. Olympic team, what would the benefits be? Potentially some, but what would happen if we were to actually address disparities? And we had the data that looked at communities where the rate of biological aging, that speedometer, was high. If we could focus those interventions there, that's where we could increase health span, increase the average life expectancy, increase, not necessarily increase lifespan, as Jay has said, that which may be, sort of provide you diminishing opportunities. But if we can address those disparities, I think that would be a way that's easily within our biology, because we know across the street in Chicago that we see that every day. That I think would be the ticket.
All right, so Dr. Olshansky, I'm going to turn to you because this is the first audience question. We have such market interest and investments in life expectancy. Extending life expectancy. How do we leverage this market interest to better support increased health span?
I'm not quite sure I'm getting the question. How do we invest in extended health span?
How do we leverage all of this market interest in extending longevity to focus on what you're focused on, which is better supporting increased health span?
Oh, well, I see, in my view, the only way that we're actually going to achieve this compression of morbidity and disability and extension of health span in the end is going to be this work on the biology of aging. I think that's the I hesitate to use the word magic bullet, but it will be a magic bullet when it happens. And I no longer say if, but I say when an intervention comes online that actually allows us to extend the period of healthy life. That, in my view, is where the action is. And on the flip side, by the way, if it doesn't happen, I do fear that we're not gonna like what we see if we make ourselves live longer as a result. So in my view, it's on the biology of aging.
Interesting. Dr. Amin, I want to kind of turn to the geographic divide around longevity, and what are you seeing in the data on the urban-rural divide? And are there certain key points you want to make in seeing that comparison across the health data?
The urban-rural divide, what I was mentioning earlier about access to care due to cost reasons, people living in rural areas report at higher rates, affordability issues to healthcare and healthcare access. To the points that are being made here, one of the issues is younger people don't make it into older adulthood. And they're less likely to make it into older adulthood in the US than in other countries. We've seen increases in, for example, firearm mortality among children in the US. Firearm mortality is now the #1 cause of death for children in the US. And the US far exceeds firearm mortality rates than other peer countries.
Erwin, I want to throw this out to all of you, but I want to start with my AARP colleague. Without the COVID-19 pandemic, how do you think today's conversation would have gone differently, or would it not have gone differently?
I think that one of the things that COVID showed, it was a infectious disease that really was exacerbated by non-communicable diseases such as a cardiometabolic disease and depression. Some people call it deaths of despair. So this was something that was happening already. And if you look at the National Academy of Medicine's report on increased midlife mortality, and midlife mortality has been rising, life expectancy midlife has been dropping. You saw things like cardiometabolic disease, which had a strong racial ethnic disparity across especially around the southeastern US, or deaths of despair in Appalachia, Ohio River Valley, or mental health, firearms accidents, suicides, all occurring, in the Intermountain West. Those are all reasons for increased mortality in midlife. And that was already happening before the COVID pandemic, and that's what we saw overlaying it. But what do we do now? And I think that's where initiatives such as geroscience, which initiatives such as better data collection, so understanding where people can be helped the most, initiatives like the Global Roadmap for Health and Longevity, all of those are opportunities now, along with other activities like age-friendly cities. So that's, I think, where our hope is, but to recognize that COVID just really exacerbated what was already happening.
All right, Dr. Olshansky, same question to you.
Yeah, COVID revealed the consequences of disparities that have been with us all along. Subgroups of the population that were already in trouble were hurt the most by what happened with COVID. But don't be misled. Life expectancy leveled off in the United States and most of the world in 2010. It's not like it was not predicted. We predicted this in 2005 in an article in the New England Journal of Medicine, where we said life expectancy is going to begin declining. We predicted back in 1990 in a science article that life expectancy, the rise would decelerate. We know why. We explained it. We explained the mathematics of the life table more than 33 years ago. Nothing has changed since then. So there shouldn't be any surprises with regard to why it is that life expectancy across the globe has decelerated. Even prior to COVID, it decelerated. And of course, it is influenced by the basic biology of our species. So we have to recognize that there's something going on beneath the surface that's influencing how long we live.
Interesting. All right, Dr. Amin, the same question to you, and then we'll move on.
Yeah, and so, in the US performs well, or at least similarly to peer nations when it comes to acute intensive care, where, top-notch innovative technology and treatment solutions are needed for cancer care or stroke mortality rates. They're at least similar to other peer nations. But for systemic issues, the US consistently underperforms. In some areas has gotten worse. So maternal mortality is one of those areas where the US has been going in the wrong direction. Maternal mortality rates have been increasing. And people often ask me, is this because people are having kids later? Is this just part of what happens? And when you look at maternal mortality rates among younger ages in the US, those rates are still higher than what other countries experience for all ages. And maternal mortality rates have been increasing across the board, but they're twice as high for Black people as for everyone else.
Can I amplify something that Dr. Amin just?
Please.
So our statistics are giving us signals that something is awry here. We have just recently in the last few years gotten signals that colon cancer among Americans in their 30s and 40s is going up. There's a signal that's going on here. I don't know the exact reason why that's happening, but we have to be acutely aware when our statistics give us signals that younger people are not doing as well as previous generations, and it tells us that they may have problems as they get older, and our statistics are revealing that.
And Ian, I think that's why aging is a lifespan issue, right? I think that's where the goal of geroscience is to not only ameliorate diseases, but actually prevent diseases, to prevent cancer, but those interventions will have to occur earlier, and it have to occur at the right time, right? So physical resistance exercise is excellent for many people, many ages. As you get older, that may not be useful. There's specialized medications that we anticipate in the future that eliminate senescent cells. That has to be done at a certain life stage, not, for example, in the middle of an acute cancer experience, right? So I think that's where, and just like with AARP, why thinking about retirement at 65, if you want to retire at 65, you should think about that at age 50. If you're thinking about health and longevity, that has to be done across all life stages. I think that's an important piece. And education and childhood and adolescence, that's all very much a part of that, which which is why I'm so proud of AARP that we address those issues as well.
Okay, so we're on to our last question. I'm going to ask you to do this in 30 seconds or less. I know it's going to be probably too monumental a task, but we're going to give it a shot. Dr. Amin, I'll start with you. What would you like our audience members to keep in mind or do after today's event? One thing that you think that's really important that they take away.
Well, the bottom line here is for how much the US spends on healthcare. The US spends most among peer nations. The US gets least in terms of long-term health outcomes, so long-term mortalities and life expectancy.
All right, Dr. Olshansky.
Read up on geroscience. This is going to be the public health innovation of the 21st century. Familiarize yourself with it.
Great. And Erwin.
As we think about disparities, we need to obviously involve personal choices, but these are systemic societal issues, and that we need to, you think about what equity of outcome. It will require a focus of attention, of resources, on programming, on communities that have historically not done as well, but should be doing better and should be improving at a faster rate than the rest of society.
That's all the time we have today. I want to thank all of our speakers, Dr. Amin, Dr. Woolf, Dr. Olshansky, and Dr. Erwin Tan, to all of our engaged audience members as well for joining us for today's conversation. I invite you to join us again later this year and look for another invite to our second session in this Longevity Plus series, where we will be exploring new frontiers in the extension of human life and what they mean for our collective futures. Have a wonderful rest of the day, and thanks again for joining us today.